Good morning. My name is Dr. Karen Muschler, and I'm one of the medical toxicology fellows at Rocky Mountain Poison and Drug Safety. I'm lecturing today on chemical warfare agents, and in particular, the nerve agents. These are some mandatory disclosures, and I have no relevant conflicts of interest. A little bit about chemical warfare history and theory. I know these lectures are meant to be quick and speedy and to the point for an emergent time and diagnosis, but there's some important relevant historical facts when it comes to chemical warfare. First things first is that historically, chemical warfare is more interesting. It's used as a tool to maim necessarily than as to kill. And so usually the goal is to harm a large number of people, but not necessarily kill them in a short period of time. This translates to the modern era as significantly large mass casualty incidents that put significant strain on financial and hospital resources, more so than actually causing significant long-term harm to people. We see more of these mass casualty incidents throughout history with the 1980s use of these nerve agents in Iran and Iraq, and then the use of sarin gas in the Matsumoto and Tokyo subways in the 1990s. However, as the years have progressed, these agents have been used more for single person assassinations and assassination attempts, as we've saw in 2017 through 2020. Many chemicals can be used as chemical weapons, but they're not all the same, and their treatment is not all the same. This lecture is going to solely focus on nerve agents, which are organophosphates. That's important to review some basic neurochemistry, though. The organophosphates are agents that predominantly interact with acetylcholinesterase, an important enzyme in predominantly the parasympathetic nervous system. Multiple large ganglia in the nervous system and extending to the periphery use acetylcholine as its primary neurotransmitter, as you can see on that diagram on the left. When you inhibit the ability of normal acetylcholine transmission, we get fairly predictable effects, which is the hallmark of these agents and exposure to these agents. When you inhibit those junctions, you end up with the downstream effects as listed there, which in the central nervous system is going to manifest as confusion, agitation, seizures, and coma. And there are going to be the peripheral effects that I think many people are familiar with, which is what we call a cholinergic crisis. So you're going to see people with profuse and profound salivation and bronchuria, bronchospasm, slow heart rates, Brady dysrhythmias, meiosis in the pupils, as well as defecation, urination, and other features from that direct cholinergic exposure. That exposure is consistent regardless of the type of organophosphate you're exposed to, which means we have many family members here. When it comes to the nerve agents, we have those lettered agents, G, V, and A, but they're not the only organophosphates you can come into contact with. Many pesticides that are used commonly are organophosphates, as well as some drugs that are still used pharmaceutically, particularly in the treatment and management of conditions like Parkinson's disease and Alzheimer's. The agents are pictured here. The phosphate backbone that you can see in each one of these is the hallmark of the toxicology of these agents and how they do the things they do and why they cause the harm that they do. So all of these agents cause different amounts of harm, but the way in which they interact at that acetylcholinesterase enzyme predicts their overall toxicity. To name some of the agents that we're going to discuss, the G agents are pretty much what people think of as the classic organophosphate nerve agents. That's soman, tabun, and sarin. In the more modern family, we have the V agents, which are VX and VG. Then there's the newest family of the A agents, which are then also called Novichok agents. These are all numbered, A230, A234, substance 33, and a long list of more chemicals that are not public knowledge as of yet. When it comes to those pesticides and carbamate drugs, we have drugs that most providers are fairly familiar with, things like neostigmine, physostigmine, and then some of our pesticides, malathion and parathion. And you can see in those images below that there's some structural similarities with all of these drugs. What they do is this. Now, certainly you're not going to be tested on this finer points of organic chemistry, but it's included here because it explains all of the pathophysiology that we see. Essentially, all of these chemicals attack a serine residue in the acetylcholinesterase enzyme. They attack at different speeds and with different tenacity. And so the toxicity from these agents depends on the speed and the permanence of this reaction here on the right, a process that we call aging. This aging process helps predict how sick people are going to be and how long they're going to be sick and what drugs and agents we can use to help manage and treat these folks. Drugs like carbamates, which is pyridostigmine and physostigmine, will never undergo this aging process. They interact at this enzyme and at that same site, but they never will finish this reaction. And so they will never cause permanent inhibition of the acetylcholinesterase enzyme, which is why patients can end up quite sick from the overdoses on physostigmine or pyridostigmine, but it's not permanent. Once we remove the drug and treat the patients, they do just fine. However, when this reaction is permanent at that phosphate, at that serine residue by that phosphate leaving group, that is where we have irreversible inhibition of the acetylcholinesterase enzyme. If it is irreversibly inhibited, we cannot use the obidoxime or palidoxime family of drugs to try and prevent the reaction from happening. And we have to wait clinically until the patient is able to synthesize more acetylcholinesterase enzyme at those neuromuscular junctions in order to regain normal function of their sympathetic nervous system. Again, that process is called aging. Aging is defined in time. And again, the carbamates will never age, but other agents do it at different speeds, as seen here. Soman, again, one of those gaseous agents, will age within minutes. So within minutes of exposure, patients' acetylcholinesterase enzymes will be irreversibly inhibited, and essentially our ability to treat these patients is rapidly falls off. Sarin takes a little bit more time, 3 to 5 hours. Tabin takes 15 plus hours to age, and VX, to our knowledge, takes over 40 plus hours. So patients who are exposed to something like VX have more time to be treated than patients who are exposed to Soman. There's some other factors to consider with these gases. And their pure forms, these gases are odorless and colorless at standard temperatures and pressures. And they're generally denser than air, which means if you are in closed environments and low-lying spaces, the risk of exposure and the duration of exposure is higher. Some additional factors to consider with chemical warfare agents. In their pure forms, these agents are odorless and colorless gases at standard temperatures and pressures. So that is sarin, soman, and tabin are all gases at standard temperatures and pressures. They're denser than air, and so they tend to collect in low-lying spaces and in enclosed areas. So if you refer back to the Japanese sarin gas attacks in the subway station, it's part of the reason it was a effective agent of theirs because it's an enclosed space that is subterranean. Their environmental persistence of these agents varies based on the individual agent. Environmental persistence is pretty self-explanatory, is how long those agents stick around in a given space. So if you have low-lying enclosed areas, they stick around a lot longer than in an open field. VX is different. VX is not a gas at standard temperatures and pressures. It is an oily, slimy liquid. And so that is patients who are exposed to VX are more likely to spread it to others because it doesn't evaporate away and it doesn't wash away naturally. Furthermore, in the 2017 assassination of Kim Jong-nam in Kuala Lumpur, that's part of that persistence is why the Kim Jong-nam died very quickly from his VX exposure on his face, and the 2 women responsible did not, because they were able to remove the agent so quickly. And so these agents can be relatively hard to detect. There's not like a given smell or other scenario that should immediately clue you into their presence, as long as people are not getting, or if people are not getting sick. This matters though because of some other considerations. First and foremost, mass casualty incident management. When the Japanese subway attacks occurred, there were 12 people who died from complications of nerve agent poisoning. However, over 5,000 people showed up to hospitals in and around Tokyo with concerns from exposure in the first week after the incident. So the patient burden, the time burden, the stress on EMS and hospital systems was tremendous, but the overall mortality was quite low. It's also important to consider for our EMS colleagues that if you are going into a situation with an unknown agent, PPE is going to be vitally important. The gaseous agents last for about 30 minutes in an open air environment. So 30-ish minutes that people are at risk for exposing others if there's gas on their clothes or that they are exhaling. And so EMS has to maintain PPE, which includes respiratory PPE, to try and prevent exposure themselves. Furthermore, specific antidotes and treatments that are required to be given in a very timely manner in the first few minutes, obviously, if it's a Soman attack, with longer times for other agents to be life-saving. These agents are stored in large depots around the country in something called the Strategic National Stockpile, but they still might not be readily available in the first few minutes after an incident. So knowing what we do have and what we can use is vitally important. And those access to those anecdotal supplies might be somewhat limited. Again, some of these agents work very quickly, and so minutes matter. And while the strategic national stockpiles are located throughout the country in a number of specific locations, the ability to liberate one of those stockpile drugs to your facility might be limited. So when it comes to clinical presentation of these patients, there are some important things to consider. First and foremost, as demonstrated on this slide, there is a dose response curve. Patients who are only a little bit exposed to a gaseous agent might only have a few symptoms versus those who are critically exposed and have acute threats to their life will have more of these symptoms, and it's organized left to right. These same signs and symptoms will be present regardless of the type of organophosphate you're exposed to, whether it is a nerve agent gas attack, whether it is an intentional pesticide ingestion, whether it is an overdose of carbamate drugs. They all can present this more or less the same. There is some degree of variation based on timing, but overall, you can see all of these symptoms in all of these patients. The most minor gaseous exposed patients are going to develop oculofacial symptoms. They're going to have miosis, lacrimation, and conjunctivitis. So tiny pupils, teary eyes, and probably ocular irritation. As doses increase and as the exposure to the gas increases, you're going to end up with runny nose and drooling, so rhinorrhea and sialorrhea. As exposure continues, we get to what we call the killer bees of any cholinergic crisis, which is bronchorrhea, bradycardia, and bronchospasm. That is essentially lots and lots of fluid in the lungs, a slow heart rate, and constricted airways. Those are what ends up being fatal for patients who are victims of cholinergic crises, regardless of the source of the cholinergic crisis. So again, it doesn't have to be a gas attack. If you have this combination of signs and symptoms, it is very concerning for something cholinergic, and our treatment will be the same. As dose progresses, people get other bodily symptoms, nausea, vomiting, diarrhea, and this is probably going to be patients who have accidentally had diarrhea and micturated, which is urinated on themselves at the scene or at the incident. The amount of fluids coming out of a cholinergic poisoned patient is pretty dramatic. It is not a subtle finding that you're going to miss. There will be lots and lots of bodily fluids involved. Patients are also going to be a little bit sweaty and diaphoretic kind of throughout because, again, that is a predominantly acetylcholine-mediated system. And then as doses increase, you're going to end up with those central nervous system effects that will usually present as agitation and usually fairly altered mental status in these patients, seizures, loss of consciousness, and then death. Patients who die from cholinergic crises die from central apnea, which ends up being a multifactorial method of developing central apnea involving both central nervous system, respiratory center depression, as well as muscular weakness, as well as just that profound aberrant neurotransmitters when patients are very poisoned. If people survive the acute stage, they tend to develop some other acetylcholine system findings. If you're a wizard with your neurotransmitters, this is your nicotinic symptoms from acetylcholine. They tend to be much more delayed, and in patients who are severely poisoned, they will probably be deceased before these symptoms develop. In less poisoned patients, though, the longer the duration of exposure, we can actually see tachycardia and a flaccid paralysis, as that acetylcholinesterase is no longer able to act at neuromuscular junctions, and people end up with no ability to do any sort of muscular transmission. So again, worse patients are going to have seizures, and you die from central apnea. You do not die from the seizures itself or those other problems. So for some other symptoms and outcomes, the mucous membranes in particular are exceptionally sensitive to organophosphates. So very mild exposures might only develop ocular symptoms, so might only have some miosis and conjunctivitis. The route of administration does change the timing somewhat. So if your patients are exposed in a gaseous cloud, you're going to have signs and symptoms, ocular symptoms, respiratory symptoms develop far faster than if they ingest a pesticide. Patients who ingest pesticides or who are otherwise like injected with agents like the Novichok agents tend to not have as many mucosal symptoms as those who walk through a gaseous cloud. In patients who survive the acute event, oftentimes something called an intermediate syndrome develops. This is days of muscle weakness and paralysis, and particularly the respiratory muscles, that does not improve with treatment, which treatment are atropine and some of those other medications. These patients essentially just have no ability to fire those neuromuscular junctions at the diaphragm in particular, and so they're just profoundly weak. As that acetylcholinesterase enzyme regenerates, it heals over time and patients gain most of their function back. But even though they are better from an acute cholinergic crisis, they still might have some of that weakness that is going to be a bit delayed. Furthermore, for those delays, mildly exposed patients can have those ocular symptoms and those visual disturbances for days to weeks after exposure. There usually isn't any role for further specific therapies for these patients, but they can just have ongoing kind of annoying symptoms for quite some time. And for the long-term exposure, recent research has demonstrated that there's a genetic predisposition in some people to sensitivity from the actual organophosphate action at the neuromuscular and other acetylcholine junctions. And this is what we think might actually be the causative source of Gulf War syndrome for folks who have been veterans of exposures in Iran and Iraq. It's essentially they're unable to metabolize these compounds as well, and they get really prolonged neuropathic symptoms, and it can be, unfortunately, a lifelong condition for people. So when it comes to diagnosing these conditions, the short answer is they're not going to be helpful. There are some labs that are trended occasionally. Plasma cholinesterases and RBC esterases might be helpful. However, they take days to come back, even in our local facilities at quaternary and tertiary care hospitals. Patients are going to need treatment and need intervention long before you get those lab tests back. So from my practice and my perspective as a toxicologist, they're nice to send, but they're not important to have. You can do other testing, and other testing will be required as part of one's management of a differential diagnosis for these patients. But it is important to remember that if you are fairly convinced this is a organophosphate or other poison and nerve agent, no other testing should be completed until decontamination is complete. I know there's separate lectures on decontamination, so I will not go into further detail about it here. But if there is any doubt, you can obtain things like a head CT. It should be normal. There's no specific laboratory findings except the two aforementioned tests that are specific for nerve agents. So there's going to be an elevated lactate if your patients have been seizing, same if any other seizing patient. You might have electrolyte derangements from severe GI losses that, again, similar to any other severe GI loss state. Patients might be dehydrated, again, from the volume loss, but none of these are specific to these agents. There's no ability, unfortunately, to detect concentrations of these agents, and especially not in a clinically meaningful way. So I know you're wondering what to do since I've said all these things that are not helpful, but the answer is going to be treating your patients with atropine. This is the life-saving intervention and the life-saving drug, and if given early enough and soon enough, can help prevent worsening of all those other symptoms. As I'm sure you're thinking, atropine is not available in terribly high concentrations in the emergency department, and supplies tend to be quite limited. That is one of the major considerations when it comes to nerve agent attacks and organophosphate exposures, is that our atropine supplies might run out before our patients do. And so that dosing is an important thing to consider. In various severe events, it is reasonable to consider robbing your ophthalmology colleagues of maybe some of their ocular atropine, as there are some theoretical data that using those supplies might still be helpful in patients, but that should be reserved for mass casualty incident. So these are the drugs that we use when it comes to nerve agent treatment. First and foremost, and most important and most foundational, is atropine. Atropine is an anticholinergic. It works at that acetylcholine receptor junction, and it helps basically preserve function of those receptors so that patients hopefully survive. If given early enough and if given rapidly enough, it can prevent worsening of symptoms. We generally treat aggressively when it comes to nerve agent exposures and poisonings. So starting big, larger doses is reasonable for these patients, especially if you're fairly convinced that this is what is going on. And part of that speed and necessity has generated the development of auto-injectors. There are auto-injectors that are like epinephrine auto-injectors that are available to the United States military, and there are some as well in certain national stockpile depots. Those injectors usually contain atropine, usually 2 milligrams. The Strategic National Stockpile has some varying dose atropine based on patient weights, which we'll get to in another slide. And then there's something called the auxines. Now, auxines are agents that are essentially carbamate drugs that work to help prevent that aging process we discussed earlier. That aging process is, again, what it irreversibly inhibits the acetylcholinesterase enzyme. And so we give medications like pralidoxime in the United States or obidoxime if you are internationally located that try and prevent that aging reaction from happening at all. In the United States military, there are auto injectors that contain pralidoxime and atropine in a combined injection. And with the idea that getting those agents on board sooner helps prevent poor outcomes for patients. And then there's other auto injectors, and these are all going to be diazepam or midazolam containing auto injectors that are used to treat seizures if and when they develop. The traditional auto injectors in the United States military contain diazepam 10 milligrams. Midazolam is a very reasonable alternative drug. And if you have a choice between the two, there's really no preference for one agent over the other. But due to some absorption kinetics and routes of administration, lorazepam is less ideal for these situations. And then the last but not least is just going to be good supportive care, like all good things in tox. So adjunctive therapies like putting patients on ventilators early can be beneficial. Replacing electrolytes, rehydrating patients are all part of the care once you have gotten control of their symptoms with atropine. We dose atropine until essentially those killer bees I mentioned before, the bronchuria, bronchospasm, and bradycardia resolve or improve. And so heart rate should come up, airways should relax, and patients be able to breathe better. And that is where I usually adjust therapies based on that. If depending on patients were not well decontaminated before they came in, you might need to dose and redose atropine. And so these patients might need more than one round of therapy, but that is going to be the first and foremost, and the last agent is used is going to be atropine. When it comes to kids, I did mention kids before. Children are uniquely at risk for nerve agent exposures for a couple of reasons. One is they are physiologically sensitive. They are lower to the ground, so these agents are denser than air, and they're going to affect children in a greater concentration. Kiddos have higher minute ventilation, so they're going to inhale more gas per unit time than an adult will. They have much smaller airways, so that bronchuria and bronchospasm is worse for them per unit exposure than it is for an adult. And they generally have lower seizure thresholds than adults do. They are a little bit less likely to be mitotic, so less likely to have those small pupils for reasons that we don't quite understand. And they may not progress through all those same stages that I described before as an adult. And what I mean by that is they are going to get sicker faster. And so if you're watching for progression, they may just go from one to seizure and not progress to those normal stages that we see in other patients. Protocols are designed and tested on adult military men for most of these agents. And so we've extrapolated it to all other populations, but we don't have as rigorous testing and protocols for kids, for women, for geriatric populations. So we extrapolate to them that if a woman is pregnant, or excuse me, a person is pregnant, we treat the pregnant person. We don't change drugs, we don't change dosing and toxicology because we have to save the pregnant person to be able to save the baby. And if someone is elderly, there is a statistically higher likelihood of poorer outcomes. But again, we don't change the treatment regimens. We don't have other treatment options, to be honest, for a lot of these. And then you'll see that dosing strategy on the right for weight-based adjusted dosing for the little ones. Essentially, it's going to be less overall, but once you hit 30 kilograms, the dosing is going to be very similar to adult human dosing. When it comes to that differential diagnosis, there are some other things to consider because management does shift slightly. Some of our other gaseous exposures out there, like cyanide, are also odorless and colorless, but because they tend to kill so quickly, they're not a good warfare agent in the outdoor environment. So if you were to release a bunch of cyanide gas outside in a field, most of it would evaporate and very few people would be harmed. That treatment differs. It is treated with an agent called hydroxocobalamin, and that will be saved for another lecture. Similarly, another denser than air and unpleasant gas that has been used in both self-harm and in industry and in attacks is hydrogen sulfide. Hydrogen sulfide, of course, smells like rotten eggs. Everyone is very familiar with that smell, and humans are uniquely sensitive to that odor of hydrogen sulfide, and so there's that warning capacity. However, it interacts in the brain in a very strange way, and it tends to do what we call a knockdown. So a single large breath of hydrogen sulfide can essentially render you unconscious very rapidly. And those patients usually just need to be brought outside into open air, and they recover very quickly. Carbon dioxide is occasionally cited as a causative thing for group harms, the Lake Nyos disaster in particular. It is colorless and odorless, and unfortunately it acts as a pure asphyxiant. So if there's a large cloud of carbon dioxide, it's just, people are just going to be rendered unconscious. And there's nothing, again, specific to treat or to manage or do for these patients. They just need fresh air. And then our riot control agents, which again, it will be another dedicated lecture. They usually have profound mucosal effects. So lots and lots of rhinorrhea and salivation and, you know, conjunctivitis, but there's no real central nervous system effects for these patients. So they're not going to be altered. They're not going to be seizing. They're just going to have a very unpleasant runny nose. They're generally thought to be not systemically harmful, except for patients with pre-existing asthma and lung disease, just because of their more sensitive airways. If you want some more information, here are the references I've recited here. In particular, I recommend reviewing the Strategic National Stockpile information to figure out where things are in your area and what agents you will have access to. And then that second citation there from Balai Mood is the chapter on nerve agents from one of the toxicology textbooks. That is an excellent brief overview of the subject. And if you want to chat more, this is me. I'm Dr. Karen Muschler, Medical Toxicology at Rocky Mountain Poison Center. Thank you for your time.